Very good evening, dear my professional colleagues. Sorry for the technical glitch. Today we are going to talk about the empagliflozin, the molecule that belongs to the gliflozin groups are the SGLT2 inhibitors. So today's topic is the holistic cardio, renal, hepatic and metabolic care in type 2 diabetes mellitus, empowering the patient-centric outcomes. And this slide shows us the statement given by WHO, the Sustainable Development Goals to reduce the non-communicable deaths actually. So here you can very clearly see the Sustainable Development Growth Target 3.4 reduced by 1/3 premature mortality from non-communicable diseases through prevention and treatment and promote mental health and well-being. So you can see on the left hand side you can see as per the data relating to 1990, and on the right hand side you can see the data relating to 2021 actually, the top 10 causes of death in India actually. India State Level Disease Burden Initiative. You can clearly see that the infections have taken over in the 1990, and the scenario is changed that the non-communicable diseases have taken over in the 2021 census actually. So the first being the cardiovascular diseases, and followed by all the time it is the non-communicable diseases is the first cause of death in India, and followed by the infections as usual. So you can clearly see that 2021 says the cardiovascular diseases and the respiratory infections and TB, the chronic respiratory infections and the neoplasms. So this also comes under our non-communicable diseases, other COVID outcomes and enteric infections and diabetes and CKD. And the urinary unintentional infections and the digestive diseases and the maternal and neonatal causes, and the transport injuries, that is road traffic accidents and all. See, these are all the top causes, top 10 causes of the death in India according to 2021 census. So dysfunctional fat and insulin resistance is high in early type 2 diabetes mellitus. So our the type 2 diabetes scenario is totally different from that of the Caucasians, that is whites. The Asian phenotype, or you can say the Southeast Asian phenotype, which consists of our India mainly, the Pakistan, the Sri Lanka, the Bangladesh, the surrounding places is known as the Southeast Asian group. So we are diagnosed at an younger age, at least 10 to 15 years prior to the Caucasians actually. Diabetes, the type 2 diabetes. See, diabetes in the sense today I am talking only about type 2 diabetes, because empagliflozin, the gliflozins are the SGLT2 inhibitors, are the drugs of choice for only type 2 diabetes mellitus, never a drug of choice for type 1 diabetes, please. Though we are very less in obesity, but we are very high in adiposity. The central adiposity is very much high, and there is more insulin resistance than insulinopenia when compared to the Caucasians, and the greater cardiometabolic risk. For example, see, if one heart attack is recorded in the United States of America or the Western scenario, that is the European Union and the UK or the Canada or the Western scenario, 4 heart attacks are recorded in India actually. So likewise, the new term consists of the atherosclerotic cardiovascular disease that comprises of both heart attacks and strokes, because CVD means it is not only the heart attacks, it includes the stroke also. So likewise, one heart attack is recorded, one stroke is recorded in the Western scenario, into 4 times is recorded in our scenario. In that way, we are at a greater risk of the complications, as well as the mortality increases rampantly. the cardiovascular risk in newly diagnosed type 2 diabetes patients in India, and the results and the main conclusions. See, I am going little bit fast because there are more than 52 slides it seems. So let me finish it up as fast as possible actually, so that we can have the question and answer session at the end. So meanwhile, I request all the participants, if you have any queries regarding this topic, you can type your questions or queries and put it in the chat box so that I can take it up at the end of the session. So the conclusions, the newly diagnosed Indian type 2 diabetes patients are at high risk of atherosclerotic cardiovascular disease. Our data therefore support the nation that further extension of nationwide atherosclerotic cardiovascular risk identification programs and prevention strategies to reduce the occurrence of cardiovascular diseases are warranted. This is the conclusion, the take-home message from that particular, the cardiovascular risk in newly diagnosed type 2 diabetes patients in India. And 2 out of 5 patients with type 2 diabetes have the chronic kidney disease or the diabetic kidney disease in Indian diabetes clinics. 38.6% of type 2 diabetes patients have an eGFR of less than 60 ml per minute per 1.73 meters square of the body surface area, or the UACR, urine albumin to creatinine ratio, which was earlier called the microalbuminuria, was it was around or more than 30 milligram per gram. That is the microalbumin is quite evident, either in the form of the CKD or the DKD is quite evident in the form of either the UACR around or more than 30 milligram per gram, or the eGFR being around or less than 60 ml per minute. So the prognosis of the CKD by eGFR and albuminuria risk categories according to KDIGO 2012 actually. You can see this, the eGFR categories, more than 90, 60 to 89 and 45 to 59, 30 to 44 and 15 to 29 and less than 15. See, divided into 5 stages actually. Stage 1, stage 2, stage 3, 4 and the 5 is called end stage renal disease or end stage kidney disease, ESRD or ESKD. Stage 3 has got 2 components like stage 3A and stage 3B. So if we can classify and categorize this the diabetic kidney disease or chronic kidney disease, it is easy to manage the things, and with regards to the pharmacotherapy, what is to be used and what not to be used is very clear. So the CVD risk category you can see on the right hand side, and the percentage of the patients, the low risk is around the 61.4% and the moderate risk is 17.2 and the high risk is 14.3 and the very high risk is 7.1 as far as the chronic kidney disease is concerned. And to achieve India's commitment to reduce premature non-communicable deaths, the Minister of Health and Family Welfare, Department of Health and Family Welfare, it said target of 3.4 by 2030 reduce, that is what we said, the WHO, they are following the norms of the WHO actually. The reduction in by 3.4 by 2030 actually. And reduce by 1/3 premature mortality from non-communicable diseases through prevention and treatment, and promise they promote mental health and well-being. And you can see the cycle actually here. A holistic approach, patient-centric approach to manage type 2 diabetes is essential. You can see the patient in the center, and you can see the cardiovascular disease on the top, and on the left hand side you can see the chronic kidney disease and the type 2 diabetes mellitus. These are all the factors the patient encounters in particularly the scenario of type 2 diabetes mellitus. The type 2 diabetes mellitus in the form of insulin resistance and to some extent insulinopenia and the beta cell dysfunction, and it leads to hyperglycemia, which leads to endothelial dysfunction and also leads to this anemia. And the cardiovascular disease in the form of atherosclerotic cardiovascular disease, that is either 3-point MACE or 4-point MACE or 5-point MACE on the one hand, which leads to dyslipidemia, cardiomyopathy, dysfunctional fat and all. At the second hand, it leads to heart failure, the fluid overload, the neurohumoral dysfunction, and the hypertension. And as far as the chronic kidney disease is concerned, the decline in the EGFR and the albuminuria, which lead to anemia, because whenever there is decline in this the renal function, automatically the hormone erythropoietin is suppressed, which is responsible for the RBC production. So holistic cardiorenal metabolic risk reduction is essential in type 2 diabetes mellitus. Nearly 1 out of 9 Indian adults have type 2 diabetes. This is taken from the ICMR INDIAB study 17. And nearly 1 out of 3 people with suffering from type 2 diabetes have cardiovascular disease globally. Nearly 1 out of 2 people with the type 2 diabetes have left ventricular diastolic dysfunction, which is called LVDD, which can be very easily detected in 2D echocardiogram. Nearly 1 out of 3 Indian people suffering from type 2 diabetes have got the diabetic kidney disease or the chronic kidney disease. Nearly 1 out of 10 Indian people with type 2 diabetes have rapid decline in the estimated glomerular filtration rate. And the complications of type 2 diabetes mellitus increase the health expenditure by nearly 2 to 4 times. And the type 2 diabetes mellitus increases the risk of premature cardiovascular deaths by 3 to 4 times. That's what I said. That is from the Cures 150 study. So we are at risk of more risk of at least 4 times when compared to the Western scenario or the Caucasians actually. This slide shows the intensive glycemia control in type 2 diabetes may reduce microvascular risk. We clearly know that the evidence-based medicine says the very adequate glycemic control results in the reduction of the microvascular complications, the retinopathy and the neuropathy and the diabetic kidney disease, and but does not consistently lower macrovascular disease or mortality risk. This is because the macrovascular disease, which comprises of the heart attacks and the strokes and the peripheral vascular disease, they are multifactorial in origin. They are not totally dependent on the glycemic control. It is not only dependent on diabetes. Apart from the diabetes, you have got hypertension, you have got the dyslipidemia, you have got the family history, sedentary lifestyle and obesity and physical inactivity, and the lipoprotein ApoB, smoking, alcoholism. So many things are involved. So it's a multifactorial origin in the etiology of microvascular disease is multifactorial in etiology. So it cannot be totally controlled by just controlling the blood sugar. So all the time remember ABC. A stands for A1C. All the time try to keep it around or less than 7%. And B stands for blood pressure. It is absolutely as per the 2024 latest the guidelines given by the European Society of Cardiology. It should be either 120 max 130 systolic blood pressure by 80 diastolic blood pressure. Nothing else other than that. Okay. And C stands for the cholesterol, that is the dyslipidemia. And in patients suffering from this particular type 2 diabetes mellitus, it's always better to keep the LDLC below 70 milligram per deciliter. And high risk cases, it is better to go below 55 milligram per liter. And in very high risk cases, it's better to go as low as possible, that is 30 to 40 milligram per deciliter. So this cannot be achieved with simple statins or fenofibrates or the saroglitazar or the PCSK. You need to go for the ezetimibe and all also cannot bring back to 30 or 40 of LDLC. In addition to all this, you need to go for the PCSK9 inhibitors like evolocumab or the inclisiran. So these are all the studies, the EKPDS and the ACCORD and the ADVANCE and the VADT. They give us the inference that the cardiovascular disease is almost is neutral as far as the intensive glycemic control is concerned. But as far as the 1% of reduction in A1C is much beneficial in reducing the microvascular complications. And the holistic approach to cardiorenal, hepatic and metabolic care in early type 2 diabetes mellitus. You always remember the liver, do not forget the liver. Liver is now the biggest cause of deaths in India. Not only in India, all over the world. The radiologist, they write ultrasound scan abdomen, he gives fatty liver, grade 1 or grade 2 or grade 3. The fatty liver itself, that means the patient is suffering from the MASLD. Now the latest term, the earlier it was NAFLD, NAFLD, non-alcoholic fatty liver disease, and the next step was NASH, that is non-alcoholic steatohepatitis. Next is the pre-cirrhotic stage and cirrhotic stage, and next is hepatocellular carcinoma. And now the terminology is changed internationally, that it has become MASLD, MASLD. It is nothing but metabolically associated defective the steatotic liver disease actually. And you can see on the left hand side, so always remember the heart and the kidney and the liver and the metabolic control, which includes the renal and the metabolic, the people suffering from the type 2 diabetes, again the cardiovascular, the leads to the heart failure, and the metabolic that leads to MASLD, MASLD and obesity, and the kidney leads to the chronic kidney disease. So the lifestyle management that is that starts from diet, exercise, the reduction in the weight, cessation of smoking and cessation of alcohol. This is called therapeutic lifestyle changes, that is TLC. So essential treatment for risk control, that is lipid management, glycemic control. That's what I said, A, B, C, D. A, B, C and D. D is discipline, that's it. Very much discipline is very much required to control all these things. A, B, C. Lipid management and glycemic control and the blood pressure reduction and the weight management. And the essential treatment for organ protection like the SGLT2 inhibitors and the GLP-1 receptor agonists, the RAS blockade and the non-steroidal mineralocorticoid receptor antagonists. So these are organ protection, that is SGLT2 in controlling the cardiorenal, hepatic and metabolic care actually. So also the GLP-1 receptor agonists, especially where the atherosclerosis is predominant, GLP-1 receptors are the very good drugs of choice where the patient with type 2 diabetes is obese. The liraglutide and the semaglutide and the first one is exenatide, and of late so many have come. The tirzepatide has come, and prior to that albiglutide and dulaglutide, so many have come. But only the liraglutide study has shown that the liraglutide is very beneficial with regards to the cardiovascular events and as far as the reduction of weight also. So also the dulaglutide is good, and now of late the semaglutide and the tirzepatide they have head-to-head fight, and there is the only the molecule that is available orally. These are all injectable anti-hyperglycemic agents actually. The Novo Nordisk people have got the oral semaglutide, which is introduced in the Indian scenario also. 3 milligrams and 7 milligrams and 14 milligrams, but it is not affordable to even the rich segment also. It is not affordable because of its too high cost. So also the semaglutide, that is all the latest the GLP-1 receptors are once a week subcutaneous injections, including they are used otherwise as the weight slimming agents also, as approved by the USFD. Like the first one is liraglutide, second is the semaglutide injectable, and third is the tirzepatide. These three molecules are used in type 2 diabetes as well as the obese patients in the absence of type 2 diabetes also. So like RAS blockade, that is the complete the ACE inhibitors or ARBs. Never combine ACE inhibitors with ARBs, please. That leads to hazardous the kidney fulminant failure with hyperkalemia, and the patient succumbs to death actually. And there is mineralocorticoid steroid agents which are very much useful either in the management of hypertension or the resistant hypertension per se, or in the management of heart failure. Again, it is divided into steroidal mineralocorticoid receptor antagonists and non-steroidal. The steroidal are the spironolactone and the eplerenone, and the non-steroidal being the finerenone. Now it is picking up. It's a very good molecule. I think out of all the MRAs, the non-steroidal is only finerenone, which is budding up like anything, which has got the benefits on the heart as well as the kidney. So it's a molecule related to the endocrinologist and the cardiologist and the nephrologist, like SGLT2 inhibitors. And early and coordinated treatment is crucial to improve patient outcomes and quality of life. See, this is a prototype of 45-year-old male patient. The medical history diagnosed with type 2 diabetes 1 year ago with a moderately active lifestyle, and known case of dyslipidemia for 10 years, hypertension 5 years, history of excessive daytime sleepiness, family history of heart failure in mother, and BMI waist circumference, it is 30 kilogram per meter square and 40 inches waist circumference, and blood pressure is, in the clinic it is 130/80 milligrams of mercury, and the hemoglobin is 9 grams, and the platelet is 1,59,000, and the glycemic profile A1C is on the higher side, 8%, with fasting plasma glucose 134, little bit on the higher side, and postprandial glucose little bit on the higher side, 189 milligram per deciliter. And coming to the lipid profile, the total cholesterol is 173 and LDLC is 92, HDL is 44. So male patient HDL always above 40, female it is always above 50 as far as the type 2 diabetes is concerned. And triglycerides is 150, it is 185. And the liver assessment, SGOT is 36 and SGPT is 41. Grade 1 fatty liver and abdominal, that's what I said. See, this has to be viewed very seriously as far as this fatty liver is concerned. Unless you stop it, unless you take the deterrent measures to stop it, the patient is going to land up in the cirrhosis, followed by the ascites and all the complications. And next stage will be only HCC, that is hepatocellular carcinoma. And the USCR is 90 milligram per this thing, so he's got albuminuria, and serum creatinine is 1.5. We need to calculate the estimated glomerular filtration by the best way is CKD EPI is the best, the method. So 58 ml per minute is the EGFR, and the recent ECG treadmill test positive, that is the silent myocardial ischemia is a possibility. So though TMT is not very specific or very sensitive, but we still do it after the ECG, the 2D echo, followed by this treadmill test, which says positive means likely to get the inducible ischemia, and negative means not liable to induce ischemia. So, and next is the final is all the time the coronary angiogram is the one that decides whether how many blocks are there and what percentage of blocks are there. But still one is afraid of a coronary angiogram, which is it is an invasive procedure where you need to give the dye. You can go for CT angiography or MR angiography, which out of which CT angiography is more accurate. And there also you need to give the dye. The only difference between CT angiography and the coronary angiography is CT angiography, you take the report and you need again go to the cardiologist. Then again he will suggest based on that whether CAG is required or not. So instead of going for the circuitous way, you can straight away go for coronary angiogram, which is both diagnostic as well as the therapeutic also. If at all there is a block in the dominant vessels or whatever it may be, the single vessel or the double vessel which is non-dominant, that is barring the LAD and the LCX, the left anterior descending and the left circumflex, If it is RCA, but stenting is enough. PCI with stenting is enough. So coronary angiogram is much better than the CT angiogram. So the current therapy, the patient is on metformin, telmisartan, chlorthalidone, atorvastatin in the tolerated doses. They have not specified the doses, but okay. Now coming to the empagliflozin with metformin addresses the multiple risks as the vasculo-metabolic first aid in the early type 2 diabetes mellitus. Always remember, whatever be the recommendations, in the case of type 2 diabetes, whenever you come across, the first molecule to be started is the metformin along with the therapeutic lifestyle changes or the lifestyle modifications, unless otherwise metformin is contraindicated or not tolerated by the patient. This is a take-home message. Along with that, you can add the gliflozin or SGLT2 inhibitor, whatever it may be, anything is next to metformin. You can give a combination. Right now, the multiple combinations are available with the metformin and the SGLT2 inhibitors and metformin and the GLP-1, the DPP-4 inhibitors actually. So according to the verified trial, what it shows is if you combine the DPP-4 inhibitor to metformin, the longevity and the sustainability of the metformin is increased to from 3 years to 6 years. That is verified trial. And I was fortunate to be one of the principal investigators of that particular trial, which was the results rolled out in the European Association for the Study of Diabetes, EASD, September 2019, Barcelona. So you can see on the top the adiposity and in the bottom you can see insulin resistance and dysglycemia, and they leads to the failing myocardium, ischemic cardiovascular disease and the tachycardia, orthostasis and the systolic BP and the sensory loss. See, tachycardia, sinus tachycardia or the ventricular premature complexes or the atrial premature complexes or the arrhythmias. These are the signs of cardiac autonomic neuropathy. Always remember CAN. You cannot afford to forget CAN. When you take a resting 12-lead electrocardiogram, you find sinus tachycardia, don't take it so light. That is a cardinal sign of the cardiac autonomic neuropathy. Or you find earlier we used to take it so light 10 to 20 years ago. Now the scenario is changed. Even you find VPCs or APCs or the arrhythmias also, it has to be taken very seriously, because it is a sign of the cardiac autonomic neuropathy, which leads to sudden cardiac death, which we are seeing very rampantly after the COVID-19. Because of the COVID infection, the long COVID, the post-COVID sequelae, or with the vaccines we have taken. Even the micro mRNA vaccines in the US, they are also facing the same problem. Not only our vaccines, all over the world, every vaccine has got side effects that is leading to the ventricular arrhythmias or the supraventricular arrhythmias, leading to sudden cardiac death, and that's it. Sudden cardiac arrest followed by death. And the renal and the retinal dysfunction. See, these are all the complications involved in our type 2 diabetes mellitus, which can be addressed by this particular combination of the empagliflozin and the metformin. The greater HbA1c reduction with empagliflozin vis-a-vis the sitagliptin, because empagliflozin is a potent molecule which reduces the glycemic triad when compared to the DPP-4 inhibitors, definitely. So the reductions in the A1C with the empagliflozin is around 1.2 to 1.5, whereas sitagliptin is around some 0.7 to 0.94%. So you can clearly see the bar diagrams showing the baseline of HbA1c of 8%, baseline of A1c 9%, baseline of 10%. So you get the inference of this bar diagram is the greater the A1c, the greater the reductions are with this particular empagliflozin when compared to the sitagliptin. A1c reduction with the empagliflozin or sitagliptin at various baseline levels, and the black is the empagliflozin 25 milligram and the green is the sitagliptin. You can see reductions in baseline of the baseline A1c of 8 with the empagliflozin is 0.87, whereas it is 0.71 with this sitagliptin, whereas 9A1C, the reduction is great, that is 1.36% of A1C, whereas 1% with sitagliptin, and when the A1C is baseline A1C is 10, it is the reductions are more with the empagliflozin, to a tune of 1.85, and the sitagliptin 1.28 respectively. So every 1% increase in baseline A1C, the corresponding HbA1c at 24 weeks, the empagliflozin 25 mg is 0.49%, and the sitagliptin 100 mg is 0.29%, and significantly higher efficacy with empagliflozin versus sitagliptin. Actually, see, this is the companies do all the comparative studies, but it should be head-to-head comparison study. So you want to study the efficacy of gliflozin, you can either compare with empagliflozin with dapagliflozin, or empagliflozin with canagliflozin, or dapagliflozin with canagliflozin. You cannot go for a like simile, that is what the same molecules must be studied if at all you want to see which is a better molecule, whereas here they have taken one SGLT2 inhibitor and at the same time a DPP4 inhibitor, which is just a lipid, the glucose lowering agent. Beyond that, it doesn't have any greatest advantages, all the DPP4 inhibitors, and they have got some side effects also. They like saxagliptin, that induces the heart failure. So we are not supposed to use saxagliptin. It is almost out of the market. Nobody is going for saxagliptin nowadays. Only either the vildagliptin off patent, or the sitagliptin is off patent. Linagliptin is also off patent, which is available at an affordable price. And off late, by next month, the 11th of March 2025, even empagliflozin is going off patent. And now you get the flooding of this the molecule, either the biosimilars of Jardiance or the biosimilars of Glixami, that is the combination of the empagliflozin and the combination of empagliflozin with linagliptin actually. And empagliflozin improves time in range, TIR, which is very important in uncontrolled type 2 diabetes mellitus. You can see benefit of the 24-hour continuous glucose monitoring is observed from day 1 onwards and until day 8. The red shows in this, that is the blood sugar around or more than 180, and the green shows around 70 to 180 milligram per deciliter, and less than 70, the gray is the hypoglycemia actually. You can clearly see the baseline and the day 1 and day 28. You can clearly see that the time in range is very much improved. It is not above the time range or below the time range. It is time in the range which is required for uncontrolled type 2 diabetes. Likewise, you need to be with, there are two terms you have to always remember. One is the glycemic variability, and the second is the blood pressure variability. You need to monitor these two. And this is beta cell independent glucose lowering effect of empagliflozin, which helps to reduce beta cell stress for durable glycemic control, which is represented in the graphic representation actually. It is studied with multiple drugs like sulfonylureas and the metformin, with isolodendines and the DPP4, and the last one is the SGLT2 inhibitor, which is very, very effective actually. And empagliflozin rapidly clears metabolic toxicity and improves beta cell function in people with type 2 diabetes mellitus. And you can see the clinical parameters at the baseline and on day 2 and on day 14. The effect is seen very immediately, that is day 2 itself is the decrease by 25 milligram per deciliter, and day 14 it is 38 milligram per deciliter. The fasting plasma glucose and the C-peptide response and the beta cell function and the beta cell glucose sensitivity, all the parameters are improved with this particular the glucotoxicity parameters are very much improved with the usage of empagliflozin. And empagliflozin with metformin results in sustained weight loss. See, the particular molecule, even without metformin also, the greatest advantages of the SGLT2 inhibitors are they emerge as glucose lowering agents. Later on, it has shown a significant drop in the systolic blood pressure, an insignificant drop in the diastolic blood pressure, later on a significant weight reduction, and a significant protection against the heart in the form of 3-point MACE or the atherosclerotic cardiovascular disease, and the heart failure and the hospitalization for the heart failure, and the renal benefits, and the level of liver also. The transaminitis is very much reduced, and the further progression is very much stopped by this the SGLT2 inhibitor. But it is not basically pertain to only the gliflozins. There are multiple drugs have to be used, and the mainstay in this particular the MASLD is the weight loss, diet, exercise, cessation of alcohol, cessation of smoking, and weight loss. These are they come first, and then the drugs. Several drugs, including the pioglitazone, which scores first, the maximal doses like 30 to 45 milligram, and the metformin, the maximal dose of 2 grams per day, that is divided in 2 doses, and the DP4 inhibitors, and the SGLT2 inhibitors, and the GLP-1 receptor agonists, and the statins, and the phenofibrates, and the saroglitazar, and the vitamin E, that is 400 milligrams twice a day for 3 months, and then monitor the liver function tests and all the enzymes, SGOT, SGPT, and the alkaline phosphatase. So likewise it goes on like it's a multi-pronged approach along with the therapeutic lifestyle changes with all these medicines. Then only you will be able to the protect the liver. So the last benefit of this particular thing is it's going to reduce the hyperuricemia. The empagliflozin is going to reduce the hyperuricemia, which is beneficial in the patients suffering from hyperuricemia, which may be gout or non-gout, whatever it may be. If it is symptomatic, you say it is gout. If it is just elevation with no symptoms, it is non-gouty hyperuricemia. So you can see the empagliflozin versus the glimepiride as add-on to metformin therapy. So you can see the curves getting separated from the beginning. The glimepiride in the red, the dosage is 1 to 4 milligram a day, and empagliflozin always 25 milligram. You can see the reductions. The blue curve going down and down from the beginning. You can see the curves getting separated so clearly, so evidently. This is called the evidence-based medicine. And empagliflozin therapy in insulin resistance associated disorders effects and the promises beyond a diabetic stage. That's what the empagliflozin leads to. It has got the anti-inflammatory M polarization, and the decreased inflammatory cytokines, and decreased T cell accumulation, and increased adiponectin, and increased energy expenditure, and increased fat browning, and the increase in the NEFAS utilization, and the reductions in the NLRP3 expression. It is nothing but NLRP3 is the NOD, not like receptor family, the pyridine domain containing 3, and the mTOR pathway and the oxidative stress, which in turn leads to the reduced incidence of insulin resistance. So when insulin resistance is reduced, automatically, inversely, the insulin sensitivity increases. Thereby, we have got a better glycemic control. So this is the role of empagliflozin, and this is about E-lift study. As far as the role in the liver, I said empagliflozin reduces hepatic fat content in people with type 2 diabetes and MASLD. That is E-lift study. You can see the control and the empagliflozin on the left hand side, and the p-value is for this control group. It is statistically significant, though not statistically very significant, whereas with empagliflozin it is 0001, that is, it is statistically very, very significant. And the ELIF study is an RCT randomized controlled trial in 42 patients with type 2 diabetes and mast cell. Empagliflozin was a standard treatment control for 20 weeks, which has shown the reductions of 4% greater absolute reduction in liver fat achieved with empagliflozin versus control group, where the p-value is 0.001, which is statistically very, very significant. And 18% patients in empagliflozin group achieved normal liver fat content versus 5% in the control group. So empagliflozin, as I said, though it is not mentioned in the title, I said the cardio, renal, hepatic and metabolic outcomes. Empagliflozin reduces liver fat content as compared to sitagliptin in people with type 2 diabetes and metabolically associated fatty liver disease. That's what mast cell. The intrahepatic lipid content measured by the protein MR spectroscopy, it is studied at the baseline and at the end of 12th week. Actually, you can clearly see the reductions with the empagliflozin when compared to the sitagliptin. And empagliflozin use improves insulin sensitivity in people with type 2 diabetes and high insulin resistance. Actually, this is based on the HOMA-IR and the fasting insulin and the remnant-like cholesterol. So the SGLT2 inhibition modulates NLRP3 inflammasome activity via ketones and insulin in diabetes with cardiovascular disease. That's what I said earlier, what is NLRP3 is. And again the same continues. And the SGLT2 inhibition has favorable effect on renal anemia actually. So SGLT2 inhibitors and the kidney, it increases the erythropoietin, I have already mentioned, and at the level of heart increases the energy production, and the erythropoietin, whenever it is increased, it acts on the bone marrow, it increases erythropoiesis and the erythroferron, and at the liver it reduces the hepcidin, thereby it reduces the hepatic fat deposit actually, leads to the increased iron absorption from the duodenum and increased iron release from the reticuloendothelial cells, that leads to the increased iron bioavailability, which leads to the reduced incidence of anemia, and it improves the hemoglobin actually. See, the take home message in Indian scenario is the anemia, you cannot take it so light. Most of the cases of heart failure in the absence of diabetes or even in the presence of diabetes, anemia, the gross, that is less than 6 grams of the hemoglobin is the number one killer in the form of heart failure. The anemia, the iron deficiency anemia related heart failure is the number one killer in India and in most of the developing countries, especially in the females. And empagliflozin use leads to 51 lower risk of anemia, that is taken from the Emperor reduced, you can see in the graphic representation actually. So see, the empagliflozin attenuates the renal tubular ferroptosis in diabetic kidney disease through AMPK bar NRF2 pathways. It is nothing but AMPK NRF2 pathways is nothing but the AMP activated protein kinase, the nuclear factor erythroid 2 related factor 2, and the take home message is that ferroptosis is an iron dependent form of oxidative cell death, a key mechanism in vascular complications of the diabetes. Hyperinsulinemia increases uptake and storage of free reactive iron in several tissues, leading to increased risk of ferroptosis. And in chronic metabolic disease, the reduced activity of antioxidant enzymes like glutathione peroxide, which enhances the risk of ferroptosis. Empagliflozin improves glutathione peroxidase activity in the endothelial cells, cardiomyocytes, and the renal tubular cells, which reduces the risk of ferroptosis. Apoptosis is that is a programmed cell death. Here you call it is ferroptosis, where the ferritin is is killed actually. The AMP kinase agonism with metformin potentially increases this protective effect. So it has got a synergistic effect when you combine empagliflozin to metformin. So the starting treatment with this particular the type 2 diabetes, that is de novo type 2 diabetes or newly detected drug naive type 2 diabetes, it is always better to give a combination of metformin, the 1000 milligram sustained release, and the combination of the empagliflozin 25 milligram plus linagliptin 5. That is the triple drug, excellent triple drug, which takes care of all the metabolic defects actually. And empagliflozin facilitates BP goal achievement in resistant hypertension. I have told you already, in patients with type 2 diabetes and with cardiovascular disease, this is taken from empiric outcome actually. You can clearly see that there is a significant reduction in the systolic BP on the left hand side, which a marginal the reductions in the diastolic BP, that is 4.5 systolic millimeters of mercury is reduced, where the p value is less than 0.05, and where the diastolic BP is reduced by 1.7 millimeters of mercury, that is even the p value is 0.05. So both are statistically significant. So the SBP goal reaches the achievement at end of 12 weeks. The patients with type 2 diabetes and resistant hypertension, you can see the placebo was able to reduce by 26.4%, whereas the empagliflozin was able to reduce the 37.7% of the blood pressure, which is very significant actually. So addition of empagliflozin is a very good drug of choice in resistant hypertension or the nocturnal hypertension, because it reduces the significant reductions in the systolic and non-significant when compared to systolic in the reductions in the diastolic blood pressure. And the empagliflozin improves cardiac autonomic neuropathy. That's what CAN outcomes. This is taken from the SCAN study. The real world evidence in people suffering from type 2 diabetes with vasovagal syncope. This is the greatest advantage with empagliflozin, where other no other gliflozin can manifest this particular the outcomes actually. The SGLT2 inhibitor use results in lower risk of recurrent syncopal attacks. You can clearly see the curves getting separated even from the beginning. The SGLT2 inhibitors, it is shown to be very less, whereas when compared with the non-SGLT2 users, which is in the blue line, and SGLT2 in the red actually. And also the empagliflozin lowers the new onset of OSA, obstructive sleep apnea. Empagliflozin versus placebo in patients with type 2 diabetes and the CVD empiric outcome trial. You can clearly see this, the changes in the weight and the SBP and the hematocrit and the HbA1c only partly explain this observation benefit actually. So though it is there, but the placebo in the black and the pooled empagliflozin in the red, you can see the reductions in the incidence of OSA, that is 52% reductions in the relative risk of new onset obstructive sleep apnea with empagliflozin versus placebo, because OSA is directly associated to the heart attacks. That is the take home message. So you need to take care of this OSA by doing the sleep studies and the sleep sonography studies and all. Either the pulmonologist or the sleep medicine specialist, whether he advises you either the CPAP or BiPAP, you have to use it throughout your life, or else you will land up in the atherosclerotic cardiovascular disease. Sudden cardiac arrest and sudden cardiac deaths are seen in the obstructive sleep apnea syndromes. And empagliflozin reduces the risk of CV death early in patients with the type 2 diabetes and the cardiovascular diseases, empiric outcome. And you can see on the left hand side and the right hand side, you can see the graphs and significant reductions the patients who are on the empagliflozin when compared to the placebo arm. And empagliflozin reduces the risk of first and recurrent CV outcomes in patients with type 2 diabetes and atherosclerotic cardiovascular disease. taken from the Empiric outcome trial, 21% in the risk of myocardial infarction events with empagliflozin versus placebo. And again, empagliflozin use reduces the risk for cardiovascular death or the hospitalization for heart failure in patients with heart failure across the left ventricular ejection fraction spectrum. The Emperor studies, actually you can clearly see that the Emperor reduced, Emperor preserved, and the Emperor preserved. What it shows in the form of the bar diagrams. The placebo is the black and the empagliflozin is the green. So again, this is all the beneficial effects of this. The worsening of nephropathy and the progression to macroalbuminuria is reduced by 38%. The risk reduction and doubling of the serum creatinine. These are all the benefits with the usage of this particular molecule, the empagliflozin. Empagliflozin consistently improves the kidney disease outcomes in patients with the diabetes and CKD, that is taken from EMPA kidney actually. The kidney disease progression in diabetes with CKD, you can clearly see that there is 45% risk reduction in the empagliflozin group, and the kidney failure in diabetes with CKD, 41% of risk reduction is seen with empagliflozin. These are all the benefits of the empagliflozin on the heart and the kidney and the liver, and even the cardiac autonomic neuropathy, and the reductions in the serum uric acid levels, and the reductions in the incidence of vasovagal syncope. These are all the greatest benefits. Empagliflozin use may potentially delay the ESKD up to 27 years and avoid 4,000 hemodialysis sessions in patients with CKD, that is taken from the EMPA kidney study. You can clearly see this the figures actually. The empagliflozin facilitates regression of albuminuria in patients with type 2 diabetes and CVD with prior albuminuria. The results are similar to the RAS blockade, either the AC inhibitor or the ARBs. They have got the similar activity. So the finerenone also got the similar activity, and empagliflozin has got the similar activity of the RAS blockade by reducing this the progression of albuminuria to the overt albuminuria to either the microalbuminuria or microalbuminuria to normoalbuminuria. So the patients with type 2 diabetes and ASCVD, only empagliflozin has proven significant 38% risk reduction for cardiovascular death. You can clearly see this the outcome trials actually. See the SGLT2 inhibitors and the cardiorenal outcomes in type 2 diabetes with ASCVD. Summary for patients with type 2 diabetes and atherosclerotic cardiovascular disease in SGLT2 inhibitors with the cardiovascular outcome trials actually. Empiric outcome is empagliflozin, canvas is for canagliflozin, declared TIMI 58 is dapagliflozin, Vertis CV is for erythrogliflozin, which is not in India. So as of now we have got only 3 molecules approved by USFDA, that is the empagliflozin followed by DAPA and the canagliflozin. Whereas in the United States you have got the etugliflozin and epragliflozin and sotagliflozin actually. So which has got the dual mechanism of action. Sotagliflozin is the only gliflozin that the inhibits the SGLT2 1 receptor and SGLT2 2 receptors actually, that has got dual mechanism of action. You can clearly see the major adverse events and cardiovascular death, all-cause mortality, hospitalization for heart failure, chronic kidney outcomes. When you compare with all these molecules, the canagliflozin and the dapagliflozin and the Vertis CV, that is etugliflozin, empagliflozin proves to be a much better drug when compared to all the other gliflozins. By the reduction of 14% in major cardiovascular events and the 38% risk reduction in the cardiovascular death, 32% risk reduction in all-cause mortality, 35% risk reduction in hospitalization for the heart failure, and 46% of risk reduction in chronic kidney outcomes respectively. Whereas the others in the preliminary studies have not shown these type of effects, and later on dapagliflozin has come out with the DAPA CKD, the DAPA HF and all, so many, and the canvas has come with this particular credence, the kidney studies and all. So later on they are also proved to be the similar drugs, but empagliflozin scores over all these molecules to some extent actually. And these two molecules are the only two molecules, that is empagliflozin and the dapagliflozin are the only two molecules which are they approved by USFD to be used in heart failure in the absence of type 2 diabetes. Even in normal patients who have got the heart failure, these are the only two drugs approved by USFD to be used in the absence of type 2 diabetes mellitus. And empagliflozin demonstrates consistent benefit for cardiorenal outcomes in routine care settings for type 2 diabetes. That is taken from the EMPRISE study. The cardiorenal outcomes with empagliflozin versus GLP-1 receptor agonist in patients with type 2 diabetes. You can see the cardiovascular death or the hospitalization for heart failure, the SKD, CV death, all-cause mortality, MI stroke. There you find all the time the betterments with empagliflozin when compared with the GLP-1 receptor agonists. And this is taken from ADA 2025 actually, the use of glucose lowering medications in the management of type 2 diabetes. You can Google, you have these recommendations in the net actually. So the 2025 guidelines are rolled out on December 15th of 2024 itself. Everybody has to take a printout of it who are interested in treating the type 2 diabetes or the type 1 diabetes or the GDM or the other specific types of diabetes. You want to manage in a much better way, in a way with backed up the evidence-based medicine. You have to be thorough with these algorithms actually. This is the same actually. And back to case prototype 45-year-old, and they see everything. The current therapy is okay. The holistic benefits of adding empagliflozin on top of standard care in 100 such patients with type 2 diabetes and cardiovascular disease for 3 years has resulted in 100 patients with type 2 diabetes and CVD in 3 years has resulted in the 9.8% CV events were prevented, 8.5% of CKD events were prevented, 3.4 AKI or ARF hyperkalemia events prevented, 12.9 insulin requirements prevented, 5.1 additional SBP goals achieved in the resistant hypertension, and 5.5 the edema, the new OSA events prevented, and 3.4% of total additional life years gained. These are all the advantages if you add on top of the standard care of diabetes. This particular molecule empagliflozin is added to that particular patient to what we have seen the prototype. These are all the benefits the patient gains. And I think we have come to the last slide. This is the take home message actually. I have given you the gist of it in the middle itself, the benefits of the empagliflozin. In early type 2 diabetes, initiation of empagliflozin can be relevant in the effective glycemic control, low risk of hypoglycemia, improved time in range, weight loss, including reduction in dysfunctional ectopic fat, and improvement in insulin sensitivity and beta cell functioning, sustained reductions in the blood pressure, reduced risk of major adverse cardiovascular events and cardiovascular death, improvement in heart failure outcomes in broad group of eligible patients, improvements in heart outcomes, kidney outcomes across the spectrum of CKD risk, and optimized clinical considerations of the risk benefits of each anti-diabetic therapy in principle of individualized approach for every patient. And thank you so much for the patient listening. And if you have any questions, please you can either unmute and ask me, or you can type and put it in the chat box so that I can take up in the QA session. I'll wait for 5 minutes.
Krishna, one question.